Singer. He is a board-certified cardiologist, joined the Dean Clinic in 2004. He received his medical degree at the University of Chicago Pritzker School of Medicine and did his fellowship and residency at Stanford. You might recognize him because his likeness is on one of our cardiac vans. So he is all around the city on the face of our cardiac vans, and he will be going through the first part of our presentation. Christa Raymond is the nurse practitioner in the heart failure clinic, and she earned her master's degree at the University of Wisconsin. She's a nurse practitioner with us, has been with Dean Clinic since 2005. And then Regi Hise is one of our heart failure patients, and he is a corporate chef. Doesn't he look like a chef? He's got a chef jacket on. And he's the director of culinary development for Emmy Roth in Monroe. So when the presenters are wrapped up and you have a question for one of the presenters, just raise your hand, have your question written out on your piece of paper, and we'll give that to the presenter to answer. So enjoy the presentation, and thank you for coming. Now I'll turn it over to Dr. Singer.
Thank you for that introduction. This microphone on so everyone can hear me. Can everyone hear me without the microphone? Not so well.
And we're taping, so.
How's that better? Thank you. Well, thanks everyone for coming. Today we're going to talk about what heart failure is and its prognosis. Heart failure is an abnormality of the heart function that results in the inability of the heart to pump adequate amounts of blood supply to meet the needs of the body, to meet the needs of your tissues. So what happens is your tissues, first your muscles can't get enough oxygen and get enough nutrients from blood, so they become dysfunctional. Heart failure does not mean cardiac arrest, that the heart stops. That's from an arrhythmia. It's one thing that can lead to that, but it's not the same thing as cardiac arrest. And heart failure is not the same thing as a heart attack. A heart attack's when a blood vessel to the heart blocks off, so heart muscle dies. It's one of many causes of congestive heart failure, but they're not the same thing. Because everyone knows the heart's a muscle, it's the picture of a heart, but the heart has 4 chambers. The left ventricle is the main pumping chamber that pumps to your body. This other thick-walled chamber is the right ventricle that pumps to your lungs. And then there's 2 filling chambers called atria up there. And this cartoon is supposed to show what happens in heart failure. On your left is the normal heart. And in heart failure, it's usually the left ventricle that is affected, but it can be either or both. But the left ventricle, the main pumping chamber that does most of the work, that pumps to your body, becomes flabby and weak and dilated. And that's what that cartoon is supposed to show. There are many causes of heart failure, which I sort of alluded to previously, but we basically divide it up into 3 broad categories. In the United States and the rest of the Western world, the most common is coronary disease. Blockage in the arteries is epidemic in the Western world. And basically the heart doesn't work well because it has poor blood supply, so it's starved for blood. And the next big category is heart valve disease. There's 4 valves in the heart. If they become stenotic, which means blocked up, or if they become insufficient, they leak, the heart can get overwhelmed. So if they're stopped up, the heart can't pump through the valves. And if they're leaking, a lot of the blood that the heart pumps forward ends up going back into the heart. So it has to work very hard and it ultimately fails. And then the other big broad category is called cardiomyopathy. There's no problem with the blood supply to the heart. There's no problem with the valves. There's an intrinsic problem with the heart muscle itself. And again, a whole bunch of causes. This is a partial list. The most common is probably completely uncontrolled high blood pressure, when the heart has to pump against this very high blood pressure. Over time, it will get thick and it will fail. Viral infections are another common cause. In third world countries, there are certain other infections that are common that you don't see much in the United States, but are a worldwide problem. Fast heart rhythms will make the heart tire out. If someone's in a very fast heart rhythm for a long period of time and doesn't know it, ultimately the heart will fail. Toxic substances is another big category, the most common of which is probably alcohol. Alcoholic cardiomyopathy is something that we see a lot, and some people, the alcohol will affect the liver, and some people it will affect other organs, the brain, and in some people they're predisposed to getting heart failure because of alcohol. But there's a lot of other substances, and one of the other big ones is chemotherapy. Some of the drugs to treat cancers are very effective at treating the cancers, but if you use them in too high of doses or you're susceptible, you can end up with a weak heart. There are inherited cardiomyopathies or inherited heart muscle problems that will just run in families. Again, relatively rare, but you'll see that parents have, one of the parents has it, half the kids will have it, half of their kids will have it, and something to be to look for so that you know to start screening relatives. Thyroid disease is another common. And finally, I don't know if you could read this way at the bottom, idiopathic, which is just a fancy word of saying we don't know what causes it, but that's still a large category where we just don't understand why some people get a weak heart muscle. And so we put that fancy name on it. The other category of heart failure that's important is what's called either systolic dysfunction or diastolic dysfunction. Again, big Latin words, but systole is the part of the heart cycle where it contracts, where the heart actually comes together and forces blood out. And then diastole is the other part of the heart cycle where it's done contracting, but it's relaxing, it's filling with blood. And when you usually think of heart failure, you think of this systolic heart failure, basically a weak heart muscle. The heart becomes dilated and very weak. But what we're seeing more and more is people with what we call a stiff heart, this diastolic heart failure. So when you look, the heart's pumping fine, but it's very thick and stiff, and so it can't fill with blood. It's like trying to blow up a balloon that's made of very thick rubber. You can push and push and push, and it's very hard to get it open. And the problem is when you have this stiff heart muscle, even though the heart contracts fine, you look at it, it looks good, it can't fill with blood, and if it doesn't fill with blood, there's nothing to pump out. And so people end up getting heart failure and basically poor heart output. Again, this is a cartoon that's trying to show the two different types of congestive heart failure. On your left is these are cartoons of the normal heart at the end of diastole when it's relaxed, and then systole when it contracts. And in people with a systolic heart failure, the type where it's just a flabby, weak heart muscle, the heart becomes dilated and it just doesn't contract much. You just don't see much difference in how much it contracts from when it's relaxed and open to when it's pumping. And then all the way to your right is what happens in diastolic heart failure, the type where you have a stiff heart. Again, the heart's not dilated, it's thick and stiff, and so it just can't relax and it can't fill with blood. So when you get to the part where it's ready to contract, there just isn't much blood in it to pump out, even though it contracts fine. And we're seeing that type of heart failure more and more. For the people with this systolic heart failure, the type where you have this big flabby heart that doesn't contract well, we categorize how severe it is by what's called an ejection fraction. And again, another fancy term, but all that means is the portion of the blood that's ejected with each beat. So normally, if you're at rest, just sitting here right now, and your heart contracts, 60% of the blood is ejected out of the heart. And what happens with exercise, with activity, you increase your heart output to supply your muscles two ways. That ejection fraction goes up, so you can, when you're really working hard, you can get most of it out, and also your heart rate increases. In people with congestive heart failure, that's due to systolic heart failure, in other words, this thick, flabby muscle, their heart contracts much less well, so that they can only put 40% out or less. And the people who are really sick, you see them putting out only 20% of the heart with each beat, or 10% of the heart. And then they can't increase their heart output with activity, so they can't do much. And that will be important later. Next, I'd like to talk about the demographics of heart failure and why we're having this meeting and why we've gotten everyone together. Heart failure is a very, very common problem, and it's becoming increasingly common. a lot of that is because as people get older, the incidence goes way up and people are living longer. But again, these are somewhat old numbers. These are mostly from 2009. But heart failure affects over 5 million Americans per year. In 2009, about 550,000 new cases were diagnosed in the U.S. Again, varies between 400,000 and 700,000 a year. And not only is it a huge cost, medical cost to the person who has it, but it's a huge cost to our society. So this is very much on Medicare's radar and the government's radar. It accounts for 6.5 million hospital days each year, 15 million office visits because of congestive heart failure. Accounts for over 53,000 deaths where heart failure is the primary cause of death. And 80% of the people in the United States that are hospitalized with heart failure are over 65. So as a result, it accounts for about 2% of the inpatient Medicare budget. So again, it's very much on the radar screen of policymakers in the United States because it's a huge medical problem and it's a huge cost problem. And it's estimated that the U.S. annual cost for heart failure, at least in 2010, was $39.2 billion for that 1 year, and it's rising phenomenally, exponentially every year. So it's becoming more and more of a just social problem, health problem, and a social problem. The Heart Failure Society came up with this acronym for one of the symptoms of congestive heart failure. It's VACES. And the symptoms people get, the first symptom people usually get is just fatigue. They just can't do as much. They're tired all the time. The activities become very limited. When they try and walk, their legs get fatigued because the heart just can't pump adequate amounts of blood supply to feed your muscles. And they get short of breath with activity. Fluid will back up to the lungs, causing chest congestion. And when fluid's in the lungs, you can't lie flat. That's one of the first symptoms people have. They have to prop themselves up on a pillow, or finally when it gets really bad, you have to sleep in a chair at 90 degrees to be able to sleep, or you wake up gasping for breath. You get swelling. It can be anywhere, but typically we see it in the legs. And the biggest complaint that people have is they get short of breath. First with activity, and then when it progresses, you can get short of breath and rest. And this is just a picture of the most common symptom that everyone associates with congestive heart failure, which is edema or leg swelling. And again, edema can occur anywhere. It's just the ankles are where you see it. Your legs are dependent. If you're up and around, gravity pulls all the fluid down. So that's where you first see the fluid. And it's a very unique type of edema. It's not just that the leg is swollen and brawny. It's this pitting edema where you put your finger into it, and it just stays there, and you get that mark there. And that's really the hallmark of edema from congestive heart failure. And again, if this fluid's in the belly, you don't see it here, you don't see it as quickly, but you get abdominal distension. If it's in your bowel, you lose your appetite, you can't eat well, you can't absorb things well. And then if it's in the lungs, which is the other common place for it to occur, you're short of breath. And so it's this fluid that accounts for most of the initial symptoms of congestive heart failure. And how is heart failure diagnosed? Again, the first thing is a physical exam. So if you're having those symptoms, the big thing is to see your doctor. And a lot of the diagnosis can be made just by listening to the lungs, looking for the edema, listening to the heart. An EKG is very important in figuring out what's causing it. A chest x-ray will show the fluid in the lungs and around the lungs and would be routine. So some pictures in an echocardiogram, but an echocardiogram is just an ultrasound of your heart, no radiation. It just bounces sound waves off the heart, and it can give very, very good pictures of the heart valves and of the heart muscle itself, and really help determine what the cause is. We talked about the different types of heart failure. We need to separate out whether it's a valve problem, a problem with the blood supply, or an intrinsic problem with the heart muscle. So cardiac catheterization, which is putting tubes up into the heart, into the arteries, and injecting dye to see if there are blockages in the arteries, is critical for separating out, is this the type of heart failure that's due to intrinsic problem with the heart muscle, or is it due to good blood supply? And the reason that's important, if it's due to poor blood supply to the heart muscle, it doesn't get better unless you fix the heart muscle. And the same thing if it's due to valve disease, the problem with those 4 valves in the heart doesn't get better unless you fix the valves. Whereas if it's an intrinsic problem with the heart muscle, it will get better just with medications. And then finally, there are blood tests that can help determine the causes and help diagnose the congestive heart failure. So this is a tough picture if you haven't seen these before, but this is a, I don't know if we can turn the lights down a little bit. Let's probably turn the lights down a little bit just for a second. But this is a picture of an ultrasound of the heart. And the sonographer, the person who's taking the pictures, has the transducer, the imaging one right over the point of your heart where you can feel your heart. So that's sort of the tip of the heart there. And this is the left ventricle. So the blood looks black. You don't see anything. And the walls of the heart muscle reflect the sound waves, so you can see it. But you can see the walls of the heart and the inner walls. This is the mitral valve. This is the tricuspid valve. So this is the main pumping chamber that pumps to your body. You can see how the two sides of it come in to squeeze the blood out. This is the part that's squeezing to the lungs. You can see how the two sides of that come in. But the important thing is that they contract in sync. At the same time, this side contracts, and that's how you squeeze out the blood. So that's a normal heart. And this is a patient that one of my partners clipped off for me that had an ultrasound this week. And here you can see again, that's that pumping chamber, and it's not doing very much. It's just not squeezing in, so you just don't get much blood out. And the other important thing that's a little bit harder to see, as this side contracts in, this side's actually contracting out. It's what's called dysynchronous. They're not contracting in sync. And that's another big problem with the congestive heart failure. If they don't come in together, you don't pump out the blood effectively. And so that's a target of some of the devices to try and make the heart track and sync. Notice in this patient, it's the left ventricle, the main one that pumps to your heart, that's not pumping well. This right ventricle is actually coming in quite well, the part that pumps to your lungs. So this patient's quite sick, and this is classic systolic heart failure, the type where the heart's not so much stiff, it just isn't contracting well at all. So that's what we usually see. And next I was going to quickly talk about treating congestive heart failure. The one that I have in bold is the most important one. You need to look, the first thing you need to do before anything else is look for the underlying cause. It's not good just to get the fluid off and make the person feel better. You need to figure out what the underlying cause is so you can stop it. So if they have blocked arteries, you need to figure out that they have blocked arteries, restore the blood supply. If there's a problem with the valve, we need to determine that and take care of the valve. If the issue is alcohol, for example, if you get rid of the alcohol, it just gets remarkably better. So the absolute first thing you need to do is figure out, is there an underlying cause that can be treated? Medications work very well, and we'll talk about those. There's more and more devices, and I'll try and give at least one example of the devices, and then Christa is going to talk about lifestyle changes. Just quickly, some of the medications that are commonly used, the one that's the mainstay of treatment and the one that makes people feel immediately better is what's called diuretics, or whatever it calls water pills. These are medications that sort of poison the kidney and make it put out more salt and water, and that, and getting rid of that edema, getting rid of the fluid in the lungs, getting rid of the fluid in the belly will immediately make people feel much, much better. So that's the first treatment, and the first thing if someone comes into the emergency room with congestive heart failure with fluid everywhere, they'll immediately get some of these water pills, and that will usually cause immediate relief. Digoxin is one of the oldest medications that physicians have had. It comes from the foxglove plant, and that's what this is a picture of. But it's medication, it's very, very old, still used. It's probably not used as much as it used to be. Some of it, I think, is because we have other newer medications. Some of it's because there's no pharmaceutical company or no one who owns it anymore. It's generic, who really pushes it. But a very effective medication at making people feel better who have congestive heart failure, and really people who are on it who are very sick, have less hospitalizations, and often can feel much better. It also helps control the heart rate if people have certain fast heart rhythms. These are the two big classes of medications that help save lives. And again, you don't have to remember the names. Probably many people are on these for high blood pressure or for congestive heart failure. ACE inhibitors or angiotensin receptor blockers, probably some of the most commonly prescribed blood pressure medications that are around. They dilate blood vessels, so they increase blood supply and take a lot of the workload off the heart. And they can help the heart decrease in size. And these medications make you feel better over the long run. They don't work quickly like those diuretics, like those water pills, but over the long run, they'll make the heart stronger, and people who are on them with heart failure live longer. And the other class of drugs that people are commonly on that make you live longer is what's called the beta blockers. These are medications that block adrenaline, the adrenaline that's produced by your adrenal gland. But that medication, people with heart failure, by blocking the adrenaline, blocks also the toxic effects of that adrenaline over time. Again, people's heart gets stronger and they live longer on these medications. So they're commonly prescribed. There are two feared complications of congestive heart failure that lead to death. And it's about 50-50 when people, if you're going to die of congestive heart failure, if you don't get better from it, half the people die because of chaotic heart rhythms. So the heart beats so fast that it just can't fill with blood, and people pass out and don't make it. That's what happens to half the people who die of congestive heart failure. The other half die of progressive pump failure. They don't have a rhythm problem. The heart just gets weaker and weaker and can't supply the kidneys, can't supply the liver, can't supply your other organs. And there are a number of devices that are out there to try and treat both of those problems. And I was going to just show the one that's most commonly used, and I think there will be a table in the back where they have some examples of them. But this is it's called a defibrillator. It's actually a ventricular defibrillator and has two purposes. One is that it will detect those chaotic heart rhythms and actually deliver a shock to get you out of it. It can also actually sometimes pace people by doing rapid-fire pacemaker, giving a rapid-fire electrical stimulation to try and get you out of that. But it is, that function is like having a life insurance policy. If you get that chaotic heart rhythm and pass out, this will revive you and you only die once. So these can be very, very effective at preventing sudden death. So it helps prevent that 50% sudden death rate. And the other function of this device is this biventricular part, or what's called resynchronization. Remember how we looked at, when we looked at that ultrasound of that very weak heart, how the two parts of it were not contracting in sync. So when one was contracting in, the other was going out. And when the other side was contracting in, the other side was going out. This is there to try and make the two sides contract in sync. And the way that's done is the electrophysiologist, the electrical doctor, puts leads into various parts of the heart and changes when they contract so that they contract in sync. And so that part of it. So the first part, again, that I talked about, detecting these chaotic heart rhythms, is to make you live longer. This part actually makes the heart pump better, makes people feel better, and over time the heart will often get smaller and actually work better, and people will live longer just from this resynchronization. So if you're an appropriate candidate, that will make you feel a lot better. Just as a final slide before I hand it over to Christa, just talking more about the prognosis of heart failure. We've come a long way over the last 20 years, so the prognosis of congestive heart failure is much, much better than it used to be. It can be very good. The most important thing, which we often forget about, is looking for the underlying cause, not just treating the symptom, but trying to find what's causing this. Because if you can reverse valve disease, if you can restore the blood supply to the heart in someone with coronary disease, blocked arteries, you can get rid of the whole problem. So first and foremost, before you're treated, is to get this done, is to treat the underlying causes. And once that's done, medical therapy and these devices are often very, very effective. So the prognosis with congestive heart failure is often very, very good. And people can lead relatively normal lives and stay out of the hospital and go back to doing all the things they're used to doing. And I was going to hand it over to Christa to talk about lifestyle changes.
While Christa is transitioning, I just want to welcome those of you who joined us while the presentation was in process, and to encourage you to write questions if you have them for any of our panelists on the question and answer sheet, and to turn in your evaluation for us. And if your evaluation has a little sticker, you win a fabulous prize called a water bottle, what do I want to say? A water bottle from the Dean and St. Mary's Cardiac Center down in our Center for Wellness. So I will turn it over to Christa.
Well, in addition to all of the medications and the devices that we use to treat heart failure, lifestyle is really a big part of the treatment for heart failure. It's really important for patients to weigh themselves daily, to monitor for signs and symptoms of heart failure, to follow a low-sodium diet. We want our patients to remain active and exercise because we know that they do better long-term and feel better, improves their quality of life. And of course, if patients are smoking, we want them to quit smoking because of all the negative health effects that smoking has on the body. One of the first things we want patients to do is to weigh themselves daily. A rapid weight gain can be a sign that the body is starting to retain that fluid. And oftentimes patients will notice a weight gain before they start noticing some of these other symptoms of heart failure. In order to gain a pound of actual body weight, you need to take in 3,500 calories more than you are burning. So it's very hard to gain this amount of weight suddenly unless it's fluid. Heart failure patients are asked to weigh themselves at the same time each day on the same scale and with the same amount of clothes on. Everyone's weight will fluctuate throughout the day based on what they've had to eat and how much they've drank. So we really encourage patients to weigh themselves right away in the morning, first thing when they wake up. Heart failure patients also should call their healthcare provider if they have a weight gain of 3 pounds or more in a day or a week, because again, that can be a sign they're starting to retain fluid. For people with heart failure, the fact that the heart muscle is weak and not pumping as well, it causes certain hormones in their body to become activated, which will cause them to hold on to salt and hold on to fluid more easily. The heart thinks if it increases your volume, it's going to help to improve how you feel, but actually the opposite is true. We know that excessive salt in your diet can cause the body to hold even more water, and so we ask our patients with heart failure to limit their salt intake to less than 2,000 milligrams a day. To kind of put that into perspective, a teaspoon of salt is about 2,400 milligrams of salt in that amount. The recommended daily allowance for everyone in the population is about 2,400 milligrams of salt. But we know that most of the American population gets closer to 4,000 to 5,000 milligrams a day. Because watching the salt is so important, I just wanted to spend a little bit of time on giving some tips on how we can limit the sodium in our diet. Whether or not you have heart failure, it's important for all of us to watch our sodium intake because it can help us to control our blood pressure and control our weight as well. The first tip is to avoid adding salt to your food. About 90% of the salt we get is already in the foods that we are eating. So if we can avoid adding salt, you're avoiding some of that excess sodium. You also want to substitute more healthful seasonings such as herbs, lemon, pepper. There are also commercially prepared seasonings such as Mrs. Dash that you can find in the grocery store. You also want to choose low sodium products. Look for labels that say sodium free or low salt, no salt, reduced sodium, or unsalted. You want to try to pick foods that are naturally low in sodium. So these tend to be the fresh fruits, fresh vegetables, fresh meat such as poultry and fish. These foods also tend to be higher in vitamin and nutrients and lower in carbohydrates and fat, so they're healthier overall for you. You also want to learn how to read food labels. Some things can be rather misleading. Things that you may think are healthy, such as cottage cheese actually has quite a bit of sodium, whereas other things that you may think have a lot of salt may not be as bad as you would anticipate. You also want to learn what foods tend to be high in sodium so you can limit those or avoid them completely. Because reading nutrition labels is so important, I just wanted to point out a couple things about this. The first thing when you're looking at a nutrition label is you want to look at the serving size. So this is something that's pretty awful. I'm not quite sure what it is, probably a bag of corn chips or something, but the serving size is one bag. So the nutrition label is always going to be amount per serving. It's not necessarily for that whole package of food. So you want to make sure that when you're looking at the nutrition label, you're counting what you're actually eating. So you can find the sodium, you can find the milligrams of sodium. So this has 1,485 milligrams of salt for the 7-ounce bag of whatever it is. So that's 3/4 of your whole day worth of sodium, and probably not one of the best things you could be choosing. Also has 99% of your fat and 35% of your carbohydrates for the day. So leave this on the store shelf. When you're in the grocery store and you want kind of a quick way of looking at nutrition labels, you can also just look at the percent daily value. Here, this is 62% of your daily value. In general, we tell patients if it's over 25% of your daily value for sodium, just leave it on the store shelf. Don't bother taking that home with you. Here are a few examples of some high sodium food items just to kind of give you an idea of what the salt tends to be in. Usually the packaged foods like the hamburger helper, macaroni and cheese, those boxed types of dinners, canned foods like canned soups or canned vegetables, condiments, olives and pickles, ketchup, soy sauce, all tend to have very large amounts of salt, cheese, fast foods, frozen entrees or TV dinners, and processed meats like ham, bacon, sausage. We also want our patients to be able to recognize the signs and symptoms of heart failure. Oftentimes, if we address the symptoms of heart failure early, we can prevent things from getting worse by making minor adjustments to people's medication. So people that have worsening shortness of breath or wheezing or coughing, if you start noticing that you're more tired than usual or starting to have problems breathing when you're trying to lay flat or needing to sleep sitting up or with extra pillows, if you're waking up at night coughing or feeling more short of breath, or if you have that rapid weight gain of 3 pounds or more in a day or a week, or if you start noticing more swelling in your ankles or feet or the abdomen starting to feel more distended, any of those things you should call your healthcare provider. We also want our patients to remain active. Studies have really shown that heart failure patients that remain active and exercise regularly do better long term. They have a higher quality of life, they're in the hospital less often, and they live longer overall. Benefits of exercise include controlling your weight just through burning calories and improving your muscle tone, your metabolism, improving your cholesterol numbers, perhaps needing less medications to keep your cholesterol under control. Improving your blood pressure by, when you exercise, it helps to open up your blood vessels and dilates those blood vessels. Also, when you exercise, you release endorphins, which are the feel-good hormones, and it can help you to improve your mood, help you to sleep better at night, and improve your energy level overall. For our heart failure patients, we prefer that they get some type of aerobic exercise where they're getting their heart rate up and elevated for an extended period of time. Things such as brisk walking, swimming, or riding a stationary bike are all good examples because you can easily control your pace. Some general tips for exercise. One, you don't want to exercise within an hour of eating or taking your medications. After you eat, some of your blood supply will go to your digestive tract to help you take care of your food. So you want to wait at least an hour so that the blood supply is more available to your muscles. You also want to stretch before you exercise and cool down afterwards to prevent injuries. Avoid heavy lifting or overexertion. Basically anything that you have to strain or bear down to lift should be avoided. You also want to pay attention to your breathing while you're exercising. You should be able to exercise and talk at the same time. If you're feeling so short of breath you can't speak a full sentence, it's too much for you. You want to avoid exercising in extreme temperatures, whether it be heat or cold. You may need to start slowly and work up gradually and set realistic goals. Heart failure patients may need to start with as little as 5 to 15 minutes of easy exercise, resting as often as needed not to get tired or short of breath. A goal might be to work up to 30 minutes of moderate exercise 3 to 5 times per week. Quitting smoking is also one of the most important things that you can possibly do for your health. Every cigarette that you smoke can increase your blood pressure and your heart rate. It can increase your risk for blood clots and constrict your blood vessels. Smoking is the #1 risk factor for heart disease. It also causes lung cancer, other cancers, and chronic lung disease. We ask our patients to quit. We want them to know what to expect. Usually the nicotine withdrawal lasts for a week or two. There are medications that can help get people through this time, the nicotine patches, gum, inhalers. You want to commit to quit, be positive, focus on the benefits, whether it be financial, the health reasons, your own personal reasons for why you're trying to quit smoking. Sometimes it's helpful to set a quit date ahead of time, whether it be your birthday, an anniversary, the first of the month, and celebrate that day each month. Celebrate your successes. You also want to try to make sure you're taking good care of your body while you're quitting smoking, that you're eating well, that you're sleeping well, drinking enough water. This can help you to be strong and resist the temptation when times are difficult. Sometimes it can help to tell somebody else that you're quitting. Just helps you to be accountable to how you're doing. You may want to smoke fewer cigarettes while you're working towards that quit date, and also learn how to cope with urges and temptations, keeping busy, thinking of other activities to do. As you can tell from this presentation, heart failure is a very complex disease. People are on a lot of medications. There's these devices and a lot of lifestyle modifications that people have to make. And that's why we at Dean and St. Mary's have developed a heart failure program to help patients with heart failure. Our mission is to help people living with heart failure and their families understand their condition and the necessary lifestyle changes that are needed to maintain the highest possible quality of life. Our initial focus is to help people get their symptoms under control, making some fine-tuned adjustments to their medications to get them feeling well. Our primary focus is on education and close follow-up. We don't replace people's primary care doctor or their cardiologist. We're just another member of the team to help them care for their heart failure. Patients in the heart failure program are seen by an advanced practitioner, either myself or a physician assistant, and we perform a history and physical exam, go over education about heart failure, a lot of what you've seen today. We adjust medications, and a lot of the medications we use to treat heart failure can have an impact on your electrolytes and your kidney function. So we're constantly monitoring labs to make sure things are staying in check. We also have registered nurses that work in the heart failure program that see patients in the hospital and provide education. We know this is a really overwhelming time for people with heart failure, and so we don't expect them to remember all of this information in one session. So the nurses also call patients frequently at home for the first month after their hospitalization to see how they're doing. They ask them about their weights and how they're feeling, making sure they're tolerating their medications well, help to coordinate care with their primary care doctor, their cardiologist, if they have a device. Some patients have home health or nursing homes, so we're working all together to make sure people are getting the best care possible. Our ultimate goal of the heart failure program is to help patients live longer and feel better. I'd now like to introduce one of our heart failure patients, Regi Hise. He has made some amazing lifestyle changes and is an excellent example of someone living well with heart failure. To introduce his story, I just am going to show a short video clip, kind of sums things up in a quick period of time.
Only News 3, here's the story of Regi Hise. His incredible turnaround. In this well-appointed kitchen at Emmy Roth, USA,
There's more soup here, so come back at your leisure.
culinary craftsman Regi Hise works his magic.
We want to do something to drive that up and taste it the way it's cooked.
Putting together a Gruyere grilled cheese for a corporate taste test.
It's a great grilled cheese.
Hise has long been regarded as one of the world's top cheese experts.
It surprised me. I liked too immediately.
His recipes dot the menus of some of your favorite restaurants.
You got a month to develop a concept, then you got to turn it over to testing.
But good food was just one aspect of a good life.
I smoked like a chimney. I ate like a pig.
A fast-paced, stressful, and demanding life.
I was trained looking for a brick wall to run into.
That train found its brick wall, March 22nd, 2010. It was the day Regi Hise died.
I remember what it was like to watch my wife looking at me helplessly waiting for the ambulance to get here, and 911 began, and then trying to lift me onto the gurney. Whether they call it arrested, flatlining, coding, I did it about 4 times over 5 days.
The 57-year-old was down to his final breaths.
It was a very, very warm bathing white light. I felt completely at peace. I'll never fear that feeling, but I don't want to go back there till I have to.
What was killing Regi Hise was not only his lifestyle, but something called congestive heart failure.
When you have heart failure and there's something wrong with the function of your heart and the overall strength of your heart, you're susceptible to arrhythmias, which can cause sudden death.
Symptoms include fatigue, swelling of legs, ankles, and abdomen from fluid buildup, which can also cause shortness of breath when it builds up in the lungs.
I had the sore jaw, the sore left side, the clammy sweats, angina or chest pain. But I convinced myself if I just relaxed for 15 or 20 minutes, it would pass, and I got used to that.
If you have heart failure, you can be diagnosed and often treated, depending on the cause, very effectively.
With Regi, it ended in the ER, more than a month at St. Mary's, a triple bypass and a pacemaker.
I think I had to die to change my ways.
That was Regi Hise then.
This one I look like Dom DeLuise's twin.
This is Regi Hise now.
Yeah. Something I couldn't have done before.
Down 40 pounds, no hospital visits in a year. Quit smoking, and he walks every day like he's on a mission.
Feels fantastic. I feel like 20 years old. It's been so long since I can remember feeling this good.
And thanks to strong willpower and his skill in the kitchen, he has changed his diet. A big part is replacing sodium with healthier alternatives.
You can't fool yourself by getting that same effect with like a little lemon with the olive oil and vinegar here and a little pepper. Food doesn't have to be punishment. That's wonderful for 4 minutes sometimes.
And his habits at home have spread to his corporate kitchen in Monroe.
Quite honestly, it helps people around him. You don't tend to do those things. You tend to watch what you eat. His illness has made me lose 20 pounds.
D-W-I-D. Don't do what I did. Do it before it happens.
And Regi Hise will be speaking along with some of the folks for whom he is eternally grateful for saving his life at a St. Mary's Free Community Education event. It's called Heart to Heart, Living Well with Heart Failure. It's next weekend, February 18th, 9 to noon at St. Mary's Hospital Conference Center on Park Street. You can pre-register right now on our front page at channel3000.com. Again, it is free.
Thank you, and I have a different question. Can you hear me? Do I need the microphone?
Yes.
Yes.
Gotcha. Well, for a few reasons, I wanted to use that intro because it would have taken me a lot longer than it did Channel 3 to sum that up, and Mark Twain once said, if I had more time, I'd write you a shorter letter, you know? But even at risk of being the guy wearing the dunce cap that said, don't do what I did, I'm so happy they did such a wonderful job because people said it was more motivating and inspiring and uplifting. And they promised they wouldn't position me as the man who died and died and died, but the man who changed and lived. And they did a wonderful job, and I want to thank them. In all the thousands of presentations I've done, a few tricks I've learned. First thing is to say something nice to everybody. You're all smarter than me. I didn't come to one of these before it happened to me. And whether you've had heart failure, you feel you're at risk, I think there are a whole lot of things that I've had to change in my lifestyle that I might be able to help you approach those changes too. The other nice thing I want to say is one of the reasons I'm here is through the Heart Failure Clinic. And about a year ago, the last time I was in the hospital, and I'd had my, I had 3 different onsets of heart failure and pulmonary edemas the first year out of the hospital. And this lovely young lady come in. She's a team of 4 ladies. I kind of think of them as Charlie's Angels myself. And they're all at the Heart Failure Clinic. And it's they all end with A, so it's easy to remember. Christa, Jessica, Jenna, and Laura. And this beautiful young lady, Jessica, comes into my room. I thought she was a dietitian, so I was about to kick her out. Okay? I'd heard all I wanted to hear. And she said, "Do you know what heart failure is?" And I said, "Well, they told me a lot about it after it tried to kill me, but I was on some pretty whammo drugs, so I don't really remember the whole story." And she explained it, and I had remembered most of it, but more importantly, she said, "Our mission is to help you stay out of the hospital and live a normal life." And I caved immediately and said, "I'm in. When do we start?" You can't do it alone in facing these lifestyle changes. I was facing quitting smoking, type 2 diabetes, so lowering my carbs, lowering my cholesterol. Now this may make Dr. Singer pass out, but 3 months before my heart failure, my triglycerides were at 2,400. Okay? I told you I was a freight train looking for a brick wall. Now, it's not all my fault. I changed my lifestyle as much as I could, and they're still high. It's familial. It's in the genes. You've got to take help. It's not something you can just work through. I remember the first symptoms I had. I was in Heathrow Airport. Has anybody ever been through Heathrow Airport in London? They have this holding cell in the middle of the airport that you wait, and they say, "Okay, your flight's at gate 82. Leave for the gate now." Well, I had like a 60-pound carry-on with me to go to the gate. We've had a gate change and a slight delay. You need to go back to the holding area. And then they wait and they fire the gun again. "Okay, now you got to go to gate 2. And you run, and I always thought it was something I could just sit down and relax and ignore all the symptoms. And it came to pass that it wasn't. It's really hard to face all those lifestyle changes, and I don't want to use the word dying, because if you die, you get a certificate, okay? You don't want the certificate. So whether it was flatlined or resting or coding, I saw an awful lot of things that made me decide I did have to change my lifestyles. As I said before, I drank like a fish, I ate like a pig, I smoked like a chimney, I did everything I possibly could wrong, and I wanted to change. I turned over most of my international business 2 years before it happened because been there, done that, got the t-shirt, it was too stressful. But facing all these things at once just seemed impossible. I was lucky, the only way I could do it, being the obsessive compulsive type A that I am, was to be unconscious in a coma state for a week or so. And I actually ripped my own tubes out in intubation, going through the DTs, coming off, the alcohol and the tobacco. And I don't know if I could have done it on my own. It's an awful lot to face, but you need to think about the consequences of it. There were a lot of things that happened when I was in the hospital that made me think very deeply too. I came to, I was doing well after about 5 days. I first got to see my wife when I woke up, and she was sobbing, and I knew something was real wrong, and she explained the procedures they'd done. And it was really a joy that first day, even in the hospital, when I had breakfast. And right after I had breakfast, I had a blood clot go to my stent. They thought I was unresponsive for about 5 minutes before they found me. They worked on me an hour when I first came to the hospital. At this time, it took them about an hour and a half of CPR, multiple paddles to bring me back. And my brain, my memory was just wiped out of anything that happened from that point on when I came to. And as I did come to, I'm the only man in the world, by the way, who can get in trouble in a coma. The nurses told my wife not to believe anything I said, but they said, "You still have a do not visit sign. Do you want that up?" And I said, "Yes, but please let my girlfriend in." Nurse Andrea at MICU, I want to thank her for saving my life and telling my wife he's going to say crazy things. In approaching all these, I think the biggest two things that I faced were the tobacco and then the sodium. and I think reducing the sodium for me was important. The people at the heart failure clinic, I tried to help them help me, and I started to keep journals. And there are things they don't tell you in the hospital that they don't have to deal with. I travel a lot. I can't weigh myself on the same scale every day. So I got a travel scale to take with me. And I found out in my travels that I'm incredibly sensitive to sodium. And I kept having pulmonary edemas in the onset. You know, that piece that said, looking at my wife sobbing in the ambulance? No, I made a big mistake. I had my wife drive me to the hospital in the first incident on Monday morning rush hour traffic down the Beltline. And I could only do 2-word sentences, so I was saying, take PD, you know, but no. And it takes things like that to make you appreciate being able to get your breath. But I found out that even if I had egg beaters and turkey sausage for breakfast and some fresh fruit, I still started the day with about 1,500 milligrams of sodium. So I went to just some nice whole grain bread for breakfast, fruit for lunch, and I'm approaching dinner and I can have a semblance of real food. Now keep in mind, every food producer in the world, salt is the oldest preservative. If we didn't put it in cheese, and I do work for a cheese manufacturer, the mold would grow to consume the cheese itself. So it's necessary. And when I said dietitians, when they said you could never have cheese again, you should have only fat-free or reduced fat cheese. And I said, yeah, I don't know about that. If it's reduced fat cheese, it's reduced in calories from fat 35%. Instead of eating 1 ounce of cheese, what if I eat 1/3 of an ounce of cheese, but it's a 2-year-old cheddar? I'll reduce my calories from fat by 65%. So I think there are ways you can do it, but you have to be honest with yourself and do the math on that. There are a plethora of foods that you can find now that are salt-free. They've caved to demand, whether it's salt-free chicken stock, or if you get pureed tomatoes instead of tomato sauce, the difference is 4,500 milligrams of sodium in a can versus 400. It's 1/10. The other thing I kind of disagree with that's helped me is I try to use no food in my cooking, so that if I do use sodium, it's a surface salt, and it's only on my plate, it's not on everybody else's. The other thing you don't see is, if you don't think I have temptations, did you see that 2 million pounds of cheese through the caves and the windows in that kitchen? I'm facing that every day. I'm dealing with what America is trying to sell in those grilled cheese sandwiches. What you didn't see is on my end of the table, I had a big gooey bowl of pieces that I spit out after I chewed them. I can't do that. If I go to a competition to judge cheese, I can't taste 4,000 cheeses in one day. So there are a lot of things I have to do to resist that temptation every single day. And I said I think sodium was one of my biggest problems. And I did find out that all these setbacks I was having were right after I was back on my feed bag and back on the road and traveling. They hide salt everywhere. If it comes in a can, a box, or frozen, or in a package, they've got it packed with sodium. So really be careful about that and take your choices carefully so you can enjoy some normalcy in the rest of your diet. Now the other thing, in addition to sodium, and I don't want to misspeak, so please correct me if I'm wrong, but one of the ways it hurts your heart is it helps your body retain so much moisture, your heart just has to work harder to clear all the fluids it's retaining. Now nicotine's just as bad. It does the same thing, taxes your heart, but it does it in a much different way. It just automatically gives you a boost of energy and accelerates your heart. So either one of them are equally bad, and for me they were on the top of the list. Low fat we're going to talk about a little bit more at the end here. Couple things I want to first of all, how many of you have experienced heart failure? How many of you have children, grandchildren, or other family members still alive? Okay. I think there's some things you can do to break a cycle. I once told the heart failure people, I said, you're not going to get too far ahead saving old codgers like me. You got to break the cycle. You got to get involved with your family and your kids. And there are ways you can do that to help you live longer and increase the chances they're going to bite into some really great traditions as you start it. Now, the other thing was exercise. I have a few tricks myself. I have a treadmill, and I just hate it to death. It is so boring. And so I don't get out as much as I like, but I have a 2-mile route, and I do it in the morning, in the afternoon. I try to get 2 good hours of exercise every day. It's expensive, but I enjoy being able to do it and breathe like I never did before, that it becomes addictive. One of my tricks is I often just drive out to a country road or a farm road and park the car on the side of the road, and I take a walk in a different farm road every day. There's something I always do, though. I don't have it on now because I turned it off for the presentation. I always carry my cell phone with me. It's really not wise to get 3 miles down a farm road and say, oh! So, but they're little tips that have really, really helped me. Some of the other things, hospitals. Since some of you here have been in a hospital, please, anybody raise your hand and tell me if you think you're going to get some peace and quiet and a good night's sleep in a hospital. Okay, point taken. How many people liked your hospital bed so much that you wanted to go out and buy one just like it when you got home? How many of you were able to book a cheap room through Travelocity? How many of you liked the food so much you asked for the recipes when you went home? How'd you like the satellite TV? How many of you got rewards points when you paid the bill? There are a whole lot of reasons not to go to the hospital, as wonderful it is to have when it's there. And the things we're talking about, an ounce of prevention being a pound of cure, it's incredibly so. And I can't tell you how much that it came to life with me when I got home, and I still realized I had to change my lifestyle. I had to walk the walk. I couldn't just talk about it. And one of the things that inspired me is every time I had a chance, I went to visit nurses on 4 East, 5 East, intensive care unit, the cath lab, and I went by to say hi to them. And when they saw how well I was doing, and they knew where my journey had been, first they looked like they were looking at a ghost or Jesus incarnate, and then the smiles went from here to here. And I knew that I wanted to continue to make them that proud, and I'd have a hard time looking at them without trying to do something about it. My wife thinks I'm absolutely daffy for wanting to go back to the hospital because she has so many horrible memories of what happened there. And to this day, they'll all tell you, I try to come by and say hi. So a lot of what I'm saying to you is really a thank you to them. Now, when I got home the first day, there's something else. You know, they say change your lifestyles. How? What does that mean? Well, there's certain things I learned. One was that stress, which I also had to lower, is directly proportionate to people trying to live up to their own expectations. And I'm a type A, and I had to recognize it and learn to back off and let other people do what they needed to do at times. But the other thing is, before you can change your lifestyle, you have to determine your values. And it's a lot harder to do if you haven't been through something like this. But the first day you go home, you're going to find out what some of those values are. Taking a bath, showering in your own shower, sitting in your own chair, looking out the window and looking at the garden, 300 channels, you know, your own kitchen to prepare your own food. They are all of that, and also the other things and the time you want to spend with people that you still have. So if you don't learn it before, when you cave and go into the hospital and you come home that first day, sit down and write some of your values. It'll make it much easier to bite into changing those lifestyles. I cannot thank the people at St. Mary's enough in all the things they did to save my life so many times. And the same thing with Channel 3, because it really has given me a chance to talk to people and help. Now, this table I have set up over here is something I'm going to be doing. I was going to be doing a personal cooking class for someone today. It was a health professional who challenged me. She said, I want to cook better, but my father owned a convenience store, you know. I don't have time to cook when I get home. I want it to almost be ready. I don't really enjoy doing dishes, and the time I spend in the kitchen is the kind of time I don't get to spend with my kids. So I wanted to show her some concepts that I think are more than just a recipe. They're a lifestyle and a cooking style you can approach. And although it's meant to be a show for one, I'm also outfitting her for her own knife to find out what she's comfortable with. But if you wish to share in on that, I'd be happy to have you. I'm going to tell you briefly what it is. I will not go out of my way to find a zero fat or zero sodium or low fat food. When I find one I like, I jump on it. When you're in the Bahamas, they have a tradition, they call it fish fry on the beach on Friday nights. And everything they say is the opposite of what it is. If they tell you you're going to have cracked conch, you think it's going to be raw, that means it's breaded and deep fried. If they say you're going to have scorched conch, you think it's burned, really means scored and it's raw. If they tell you the fish is going to be grilled, it's actually steamed. And all the people who get this steamed fish are hopping mad when it arrives and they open the package and it's not grilled, it's just steamed. But then they look down once and they start eating and they never pick their head up. And this is a Bahamian tradition that is so flexible. I have a tin foil boat I make, and in the bottom I put chopped onions, bell peppers, a little tomato and onion. On top of that I put some plantain, a little sweet potato, a little potato. On top of that I put a fish fillet. On top of that a little pepper, a little sprig of thyme, and I put about a half a cup of chicken stock in it, squeeze a lime juice. I fold it up and I make big handles on the end, fold them over, and it can be done a day in advance. You can put it on a hot griddle or you can put it on a grill, which is I prefer. In 20 minutes when steam is kicking out the ears, it's ready. And it's the only fish dish you'll ever eat that tastes so pure, so clean. It's literally zero fat and literally zero sodium. And you can afford, if you want to, you can put a little hot pepper in it. But also, I've got variables over here. You can do the same thing with chicken. You can do the same thing with pork. You can do the same thing with a boneless chicken breast or a chicken thigh with the skin taken off. They are easy to cook, they're really flexible, and I have a way that we involve kids in it too. So, with that, thanks again to everybody at St. Mary's and all the health professionals. I'm only here because of their teamwork, and if there's anything, I'm going to try to be over at the trade show fair. I have to go down for another appointment today, but if you have any other questions, but with that, back to you. Thank you for your being here.
Very inspiring story. Thank you very much for sharing. It's 10:10 and we factored in about 15 minutes for question and answer. And so if you wrote a question for one of our panelists on your question sheet, raise your hand. Tim will come around and collect them, and then we'll bring them over to our panelists. This looks like questions for Dr. Singer and Christa. Okay.
Since you have a cardiac and thyroid issue, how can you tell if pounding chest symptoms are from one or the other? That one you need to see your physician. Your thyroid test is easy to evaluate by blood tests as well as physical exam. But you never want to be just treating the heart if the thyroid isn't regulated right. So the first thing is to have the thyroid checked.
The second question is, what do you eat when you're out? Most prepared foods are high in sodium content, particularly if you travel for work. This is a very difficult question. It is very hard to watch the salt in your diet when you're eating out. In general, we say to try to stay with as many fresh fruits, fresh vegetables, fresh cut meat, so again, maybe having a salad, ordering the dressing on the side so you make just dip the tines of your fork in it rather than layering it all over your salad. Trying to avoid things that have a gravy or a sauce. You know, and again, just trying to stay with as many fresh foods as possible.
I want to add on what Christa said, that same thing, if you do want gravy or sauce and a little is what you'd like, ask for it on the side so you can dip. Don't pour it over everything. And you don't necessarily have to use tiny amounts of salad dressing. If you use a better salad dressing, like just vinegar and oil and a little lemon, you'll be amazed how delicious it is.
Says number one, Kath, is there any other way to determine blockages? And there definitely are. For most people without heart failure, stress tests work very well. There's all different types of stress tests, so usually we'd start with a stress test. Often, you know, by the time someone has very bad heart failure, often you need to be so sure that a cardiac catheterization is the ultimate way to go. There's more and more tests to look at blockages. CAT scans can give you some hint. They're gated to the heart so that they image at a certain point. You know, your EKG is done while the CAT scan's been done, so that you don't get a blurry heart, so that it only takes pictures of the certain part of the heart cycle. But that's getting better and better, but again, often not as definitive as a heart catheterization. And the second question, does sneezing mean anything? Usually that's not from the heart. Usually that's allergies or viruses or colds.
Another question is, we do very well at home, but we have a very active social life. I think basically if they're having problems following a low-salt diet when they're out and about at friend's house. Some things that we tell people is maybe to eat before you go. You know, maybe have some fresh fruits, some veggies, you know, something so you're not starving when you get to the place where you're going. You know, again, trying to stay with the healthier, fresh foods and just limiting, you know, having very small amounts of those food items that might be higher in salt.
How early can heart failure be detected? I mean, nowadays the imaging is very, very good, so we can detect problems very, very early. Ultrasound will show minor amounts of heart problems, severe heart problems. So, you know, I think the imaging has gotten very, 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 very good and continues to get better.
I had one on here, why do the TV cooks use so much salt? Because they're trying to do their job and use every trick in the book to make the food taste better. And it's not necessary, but they face the same things you do. A lifetime of habits that they've grown up with. And so if they think of it in this way, if they keep all your sodium confined to the one dish they serve, that dish is going to be more popular. I think that we found out that a lot of manufacturers and food manufacturers and chefs could use about 25% of the sodium they do. But let me give you one example. We have a famous national chain that I work with, and they introduced a new low-sodium natural chicken broth instead of something made from crystals and packed with sodium. And their customers patently rejected it and refused to order the new soup. Well, they stood their ground and they waited, and they found out the people who enjoyed it came back and they realized how much better it was. It's hard to break those habits, and salt is just as addictive as anything else, and they know it. That's why they do it.
Questions here. See, this one's, to what extent is inflammation the cause of heart problems? And why is it to have a homocysteine and C-reactive protein test ordered? Those are all good questions, three separate questions or related questions. C-reactive protein is a measure of inflammation. And this is, again, more to do with heart attack probably than heart failure, one of the causes of heart failure. But these fatty blockages, they probably rupture or cause heart attacks when they get inflamed. These fatty blockages are covered by a scar tissue cap. And when they get inflamed, that scar tissue cap can rupture, and all of a sudden you expose the underlying fat, these blockages, and blood clots love to form. And that's when you get a heart attack. So people who have this inflammation are at higher risk. So often, again, by the time I see patients, they already have the inflammation, and so the tests have already been ordered. Got to say, so I don't order it a whole lot because it's usually been done on a lot of the patients that I see. But your primary care physicians will often get that to figure out who's at risk. If your C-reactive protein is high, your physician may want to treat your cholesterol even more aggressively because you're in the higher risk, and the statins, some of the cholesterol-lowering medications, will lower that inflammation, decrease your risk of heart disease. Homocysteine is one of those things that sort of comes in and out of fashion. I think the more recent studies have shown it's not necessarily the most useful thing to order in most patients, again, with some difference. You know, the studies, people with higher homocysteine may have a higher risk of events. There's not a lot of evidence that lowering it with vitamins and things like that will decrease those events. So it's one of those things I think right now it's sort of a little bit more out of fashion because we don't know what to do with the result when we get it. Most patients, not all, but most.
Another question was, what are some other names for sodium on the label? And that's actually a very good question. When I focused on nutrition labels, I mostly have gone over the numbers, you know, the milligrams of sodium and percent daily value. But for some of those food products that you may find that don't have the actual nutrition label, they'll usually at least have the ingredients list. And the ingredients list is always, you know, it always starts with what it has the most of, and then goes down from there. So, you know, anything basically, it'll say sodium, and then it will have another word. I don't know all of them off the top of my head, but, you know, anything like that. What was that?
Enosodium.
Yeah, yeah. MSG, you know, again, that has sodium in it as well. So at least when you're looking at the labels, those sodium products are lower on the label, it's going to be lower in salt than if they're, you know, one of the first few ingredients.
Just a word of caution about that. I mean, a lot of times they advertise sea salt instead of regular salt, but sea salt is just salt. You know, it's sodium chloride. So again, there may be, you know, maybe you like the idea of sea salt better, but as far as your heart, it doesn't know the difference. Sodium is sodium, and sea salt is sodium chloride, just like table salt.
What about kosher salt? You hear about
It just comes in bigger pieces.
Yeah, it's still sodium chloride. So again, there are some salt substitutes, and again, some of them have potassium chloride. And again, that one I'd ask your physician about. Certain medications that we prescribe raise it, or certain people with heart failure or kidney disease can get too high of potassium. Most of our heart failure patients have too low of potassium, so it's okay as long as you tell your physician or you tell your nurse practitioner so that they lower the amount of potassium in there. Some of the salt substitutes are okay. Some of the salt substitutes are things like Mrs. Dash. They're spices, so they don't contain any sodium. Those are just fine.
But the no salt is still salt.
The no salt? Well, now, no salt is often things like Mrs. Dash. If it says no salt, that is, again, you have to, yeah, or it's potassium. And again, the potassium chloride, in some patients that's fine. It's great. We'd encourage it. It means you're on less other salt replacements. Some people, their potassium runs high. So that one, I'd actually bring it in, show your physician. Or bring it in, if you're in the heart failure clinic, bring it in to Christa and Laura, and they'll look at it. But you need to be a little bit careful. But it's just the big thing is sea salt has sodium chloride, just like salt. So you have to be very, very careful about that.
There was a question on one of the sheets that I didn't answer, and someone asked about something about a scholarship they were working on for, and it was a question about animal proteins or casein. I don't know if that was what are the detriments or the attributes of animal proteins. You remember all the flap when milk came out and they had bovine growth hormone. It was, you know, RSBT or the recombinant, and that was a no-no. Well, they were talking about additional growth hormone, but whether it is a pig or a cow or a sheep, animals intrinsically have growth hormones, and those growth hormones make them bigger and sturdier. And I think it was Oprah who did the show where she first got sued and where she met Dr. Phil when she said that eating any animal proteins means you're eating growth hormones, and so the more you eat, the bigger you're going to get. Now, I don't know the true nature of that. But there are a lot of people who have switched to vegetarian and vegan because they believe those growth hormones overall are not good, separate and aside from the issue of cholesterol. Casein is the primary protein in cheese, and vegans will not eat anything that is dairy-based, but I don't know of any research that's said anything negative about casein as a protein, and I'm going to defer to Dr. Singer and Christa on those too.
I agree with just what you said. One more, I have a prolapse heart murmur. Does that mean I have a bad heart? It seems to mean mitral valve prolapse, which is sort of redundant in one of the valves of the heart. And many people have mitral valve prolapse. I think if you were to go through the dorm rooms and women at UW, probably 10-20%, depending on their hydration, how their fluid status and everything might have mitral valve prolapse. And most of those people, nothing bad will happen. Now, mitral valve prolapse in a man has a higher incidence of going on to get real mitral valve disease, but still relatively low. So I think there's many people out there that have mitral valve prolapse who will never cause a problem to. There's a small fraction that will end up getting mitral regurgitation, a valve that leaks so much that something needs to be done, but I think that's a relatively small proportion.
What is that?
Mitral valve prolapse? Well, some people will have redundancy in the mitral valve. It will just be more the apparatus. The mitral valve is a very complex structure that has two parts. One, we call a posterior leaflet, a back leaflet, and then an anterior leaflet, a front leaflet. And the back leaflet is a relatively simple structure, like a door jamb. And the anterior leaflet is a much more complicated structure. It looks like a parachute, but a very complex structure. And it's attached to parts of the heart called papillary muscles that control it. And in some people, that valve, it's a little bit redundant. And over time, the little corded little threads that attach it can sometimes break, and they can get real leakage. But that's a small minority of the people who have mitral valve prolapse, who have this redundant valve.
Another question was, why do ankles swell when on long bus tours? Usually if it's someone with heart failure, basically you have your feet in a dependent position for a long period of time. So when you have your feet down, you're going to tend to notice more swelling in the legs. You want to elevate your legs as much as possible. Also getting up and walking can just help to improve your circulation, get that blood flowing, and get rid of some of that swelling. They also asked about leg cramps. There can be a lot of different reasons why people can have leg cramps. Sometimes with the water pills, they do affect your potassium level. So that's one thing we look at if people are complaining of leg cramps, if perhaps their potassium level is a little bit too low. Sometimes it could be a sign that they're getting a little bit dehydrated, that they may be taking too much of their water pill. There are also other reasons for leg cramps that might not be related to their heart failure at all. Peripheral vascular disease too, where they have blockages in the arteries of the legs. Sometimes that can cause leg cramps when people are out walking. So if you're having difficulties with leg cramps, it is something that's important to talk to your healthcare provider about.
I asked you about olive oil.
Yes, I just did these last two.
They
What's
had
your
it
question?
on NPR, and the guy was saying that most of the olive oil on the shelf is old. And he had store in Milwaukee, and I don't know what it is, but he had people there, olive oil off the shelf, and a good quality. They could not believe the difference in flavor. So I wanted to know, what are these? I couldn't get a name of the product. I mean, I would pay more.
Well, I think what you need to do is check the code dates on the bottle. Many of them will say Best Buy. It won't go bad and it won't harm you, but have you ever had a bag of walnuts sitting around too long and they smell rancid? It's the same thing that happens to the oils. It's the volatile fatty acids, and so freshness is important. Don't buy a gallon of olive oil if you're not going to be using it. And there are a couple other things too. Some of the better olive oils go bad quickly. They're like extra virgin. They're cold pressed, they have a fair amount of sediment in them, and they can compost and rancidify more quickly. Also, you wouldn't want to use those in cooking. You'd want to use a pure olive oil, not an extra virgin, because it's more filtered, it's lighter in flavor, It still has all the benefits, but it won't burn when you cook with it,
A pure olive oil.
as opposed to an extra virgin, right?
Okay,
So I'm going to just kind of bring the group back. Sorry, if you have more questions for Regi, he will be available at the cooking demonstration. But we're coming close to 10:30 and wrapping up this portion of the Heart to Heart Living Well with Heart Failure event. I want to thank you all for coming and encourage you to stay for refreshments, and across the hall, in the back corner across the hall is our resource fair, where there will be more clinical professionals available to answer questions that can help you live well with heart failure. But before I let the group disperse, we have to pick our prize winner.